At this point, I'll ask Dr. Fabian, Dr. Inglesi, Drs. Krieger and Ben Zachariah to join me up here on the podium, and we'll be happy to take questions. There are somewhere a couple of roving microphones around our, I can't actually see who, oh, there Susan has one, and the others in the back. So raise your hands high, and somebody will come running to you.
Question?
So I can't see, I'm partially blinded by a light, so.
Dr. Fabian, you spoke about 4 different types of MS. Recently, my child, my 30-year-old daughter, has been diagnosed with schematic sclerosis, which was told to her as a form of MS. Could you please elaborate on that?
I'm not sure where you are in the audience.
We're over here.
Okay. Hi. So schematic sclerosis is not a condition I'm familiar with.
I think you or your daughter has probably misheard what the doctor said. There is no such thing as schematic sclerosis. There is another condition not related to MS called systemic sclerosis, and that's possibly the case, but it's not MS. Another question over here on my left.
Hello, how you doing? I wanted to know, if you get a new lesion, do you get an attack?
All right, I think, Michelle, you can probably answer that one.
Sure. So as I had said before, it's a good question. Some lesions will cause an attack. So it has to be in a place of the nervous system that is critical for function that you will get a symptom there. Other lesions will be silent in terms of what the patient experiences.
I wanted to know, I was diagnosed in 93. In 2004, I started Avonex, which I still take, and my neurologist now wants me to start Tysabri. I was tested positive for the JC virus. So is that like a really risky thing for me to do at this point? Do you have any recommendations?
So I'll tackle that. So, of course, you should have a detailed discussion with your own physician about that situation. And, I don't know your history, and we can't talk about your management directly here. But in general, because it takes time for PML to be a risk with Tysabri, there's an extremely low risk of PML in the first year of Tysabri therapy, even if one is antibody positive. If one is antibody negative, there appears to be close to no risk. Once one gets beyond a year, the risk is low, but not inconsequential, and so one might want to be engaged in an active dialogue with your physician at that point. The exciting news is that there are going to be additional options that come along around that time.
This is a question with Dr. Miller. Dr. Miller?
Yep.
You just, your last slide indicated the inverse relationship between childhood exposure to UV light, I assume to sun, and development of MS. Can you elaborate? Because until recently, the closer you were as a child to the equator and then moved north, that was supposed to have increased your chances of getting MS. That until now, that's the way I understand.
Right. Well, this story is all consistent. There is a lower risk of MS among people who live near the equator. People who live near the equator, among other things that might happen to them, is that they are exposed to more sunlight. Sunlight contains ultraviolet light. In one particular study that was done in Tasmania, in Australia, a rather clever technique was done. They biopsied people's skin, looking for evidence of ultraviolet light exposure. There's a measure of skin damage that reflects how much ultraviolet light exposure you had gotten. And those people with MS had evidence of less ultraviolet light exposure, less skin damage than did people who didn't get MS. So the story is consistent, but again, we can't emphasize too many times that this is an association, doesn't prove a causation.
If
Doctor?
I understand correctly,
If you have low doses of naltrexone treat multiple sclerosis, and that's good. Suppose you do not take the LDN. Would that help the MS?
Eliza?
As I mentioned, there is no evidence that LDN is directly associated with MS and improving your condition with MS. We do not also have any measure at this point to evaluate the amount of LDN that you have in your serum. So again, we don't have evidence that it's helpful. As you remember, I shared with you 2 studies by MS expert, but that show some maybe benefit to quality of life and maybe some spasticity. But again, there is no direct relationship and causation relationship between LDN supplementation and better outcomes in MS as yet. Hopefully the future will show differently.
Dr. Inglesi, over here, sorry, in the back. Is it standard order for MS patients that an MRI looks at gray matter? And is gray matter predictive of sort of degeneration or what's to come?
Could you please repeat the first part of the question?
Sure.
Is it standard to look at gray matter?
Oh, well, it is becoming, I mean, the sequence that that I showed, the double inversion recovery, is available of some of the scanner from some of the manufacturers, and the others that have not it available yet are developing that sequence. So actually, in alternative to double inversion recoveries, there are other sequences. One of these is a 3D very high resolution image that can be used also to detect gray matter lesions. So I would say that yes, it's in some centers is part of the routine protocol, and it will be available in every center soon. I
think that's probably coming, but I would say in general, looking at cortical pathology by double inversion recovery is not a part of the standard commercial MRI yet, but hopefully will be soon.
Yes, it is. In the studies that have been performed so far, it's predictive of disease progression.
Hello, doctor.
Yeah. Oh.
Doctor, excuse me?
Yep.
If you start one of these therapies, is that necessarily for life, or does it vary by patient?
I'll let Dr. Krieger tackle that.
Forgive me, I didn't see where you are, but when Dr. Miller talked about the multiple factors that go into the selection of a drug, that big wheel of all of the various components of the decision, I think it's really important that those things be taken into account when someone is choosing a medicine. We want them to choose a medicine that is the best fit for them, for their life, for their condition, etc. But it is not necessarily committing to that one medicine forever. And many times a patient will remain on a medicine for MS, a disease-modifying therapy, as long as that's the best fit for them. That could change because if their side effects become intolerable, we may want to switch them to a different medicine. If we feel that the MS has worsened, even though they're on one of these medicines, we may want to change the medicine to a different one. And so it's a commitment for the short to intermediate term. But I think in today's world where we have 7 approved drugs now, and as you'll hear from Dr. Lublin this afternoon, a whole variety of new drugs that are on the cusp of being available, I don't think the medicine that someone chooses initially is the one they're going to be on forever. I think they'll be on it until there's a better match for them and for their condition.
Yes, doctor.
We're going to go on answering questions, but now would be a good time for you to be thinking about tuna, turkey with cheese, or vegetarian. So you're ready to hit the right stand in a few minutes. Okay, another question.
Yes, I've got actually a 2-part question. They were talking about the gray matter and the relation to cognitive problems. Is somebody who has a lot of cognitive problems, would it do them good to get an MRI of the gray matter to see exactly what's going on in there?
I think I'll try to tackle that. So I'm not sure whether everyone could hear the question. The question was, if a person already has cognitive problems, would it be good to get an MRI looking at the cortical gray matter? Not necessarily, because the real issue is what are the symptoms and what can we do about them. The MRI is not going to tell us the answer to that question. I think the real utility of looking at the gray matter ultimately will be just as the other techniques we use in MRI. They guide us partly in having a better guesstimate about what the prognosis is for MS. We look for change in MRI over time to let us know whether a particular therapy is working in addition to using the clinical activity. So it's not really going to help.
All right, I also got one other question. I was reading an article by a Dr. Andrew Goodman who said that some MS patients lacked a chemical called neurosteroids. I'd never heard that before, so I wondered if you guys had heard about it.
I don't think any of us are going to be able to answer what we know Dr. Goodman well, and I'm not sure what he was referring to.
Okay.
Okay, good afternoon.
Water, air, what we drink. Now, you guys want to work with this a little bit, you're with your little itty-bitty, focus on these small things, because you're more interested in impressing us with your knowledge.
Do you have a question?
With the truth.
Do you have a question that you would like to ask?
C, A, B, and D vitamins, they're all in a character, but if I put 2 drops of arsenic in it, you'd be dead. I know how professionals are, because I happen to be a professional. You are very focused on very narrow things, knowing more and more about less and less until you know absolutely everything about absolutely nothing. Yes, what a fool is. Do you people really want to say so?
Good afternoon, Doctor. Good afternoon.
Okay.
Dr. Miller.
We have another question.
Good afternoon. I would like to know, how would I be able
Please.
Good afternoon, Dr. Miller.
Please. Sir, please. Thank you.
Yes, good afternoon, Dr. Miller. How would I be able to tell a relapse or an attack, and me as a caregiver, could I detect it?
I couldn't hear the question. Could you repeat it?
I said, how would I tell if my patient has a, not my patient, but how would I be able to tell a relapse? Like if she has a relapse, and me as a caregiver cannot detect it.
Okay, Steve, you want to answer? And repeat the question.
Sure.
Am I your patient or am I your woman?
I think the question was,
You're my wife.
I think the question was, how do you tell if somebody is in fact having a relapse?
Yes,
is that right?
exactly. Yeah, or an attack.
Sure. So, you know, when a patient with MS has a relapse, the first thing I want to just add is the terminology can be really confusing. So when we say relapse or attack or exacerbation or flare-up, all those things mean the same thing. That's the first thing. And we define that as a new or worsened symptom that has lasted for more than a day in the absence of some other trigger, like fever or heat. So if someone with MS develops a new symptom or a real significant worsening of an old symptom that comes on over a day or days and then doesn't go away, that really concerns us for being a new attack, a new exacerbation. So my advice to my patients is always, if you feel something and it concerns you and it's been there for more than a day or so, call up the person who's taking care of you and let them assess it and help figure it out. I always say this, you know, I used to say it has to last more than a day, but I get myself in trouble because one of my patients then said, well, if it hasn't been 24 hours, I'm not going to call Dr. Krieger. That's not what I mean. There's no magic to that lasting a day. But it helps to make the distinction between symptoms that come and go and something that's new and real and sticking around. So that one-day guidance, I think, is useful that way.
Yes.
Dr. Miller? I don't know, is it myth or is it fact? You mentioned about Tysabri. they took it off the market. It was my understanding that there were fatalities involved with taking the drug. You didn't touch on that, or was it just 1 or 2 people that had
Right.
this?
So PML has been associated with fatalities, and that's why it's critically important that we avoid, that we take every precaution in preventing that disease. So of those people that have gotten PML, which around the world, among approximately 90,000 people who have used Tysabri, there have been approximately 150 cases of PML. About 20% of them have been fatal, and others have left people with significant disabilities. So it's critically important that we take every measure possible to assure safety. I think we'll take one more very brief question,
Dr.
and then
Miller,
we'll do lunch.
I have a question back here.
Just hang on one second. But the panelists and other members of our MS Center will be around during the lunch period if you want to corral us and ask us other questions. Yeah.
The question is coming back from back here on this side.
Okay.
I have heard about a new procedure that's being done. It's called CCSVI. I was wondering if you have any thoughts on that.
Well, CCSVI, or chronic cerebrospinal venous insufficiency, which I talked about at length in this symposium a year ago, is a very controversial issue. It takes a long time to discuss it in length. Let me say at the moment that it falls into the circumstance of an MRI finding, or sorry, an ultrasound finding that has not yet been adequately replicated, that at the moment data suggests may, and I emphasize the may because there are many negative studies and more to be reported at a big international MS meeting in Amsterdam this coming week. There may be an association which clearly doesn't prove causation, and getting one's veins fixed at the moment appears to be premature and potentially dangerous in view of the fact that there have been at least 4 deaths around the world associated with that procedure. So
Dr. Miller, I have a brief question about the JC virus.
Last question, very brief.
Thank you. If it's indicated in blood work that you show a negative response to the JC virus, is there some kind of environmental exposure that would lead that later on you have the blood work and it would come out positive?
Yeah, we don't know how people get JC virus, but it is possible to acquire it having been negative in the first place. So you get your blood tested repeatedly, probably on an annual basis. So at this point, head for the